Hello, everyone. Let me double check if we still having connection issues. We can try to resolve that for Dr. Kebaetse. See if we.
Hi guys, we will start in a few minutes. Please just wait.
Oh, he got here. Okay, wonderful. He's here. Hey, Mike, how are you? The seminar has started. Can you? Yeah, wonderful. Okay, great. I'm so glad you were able to connect with no problem. If you can raise your camera so that your face is. There we go. Wonderful. You're muted, so you're up. You can start.
Okay. All right.
Let's just wait 1 more minute just to have all the attendees.
Okay. I'm going to be sharing screen, right?
Just 1 second, Professor, before you start sharing, okay?
Okay.
And we will start in 2 minutes. Sorry, I will start in 2 minutes.
Okay. I might have to go out of video because I have a very poor connection today. If that's okay, but we can try.
You can keep your camera off until we start to talk, or if the connection is too bad, you can just make it off because it will be easier for you to roll the presentation.
Yes. Correct. Thank you.
Hi, I think we can start it. So, hello and welcome. My name is Sonini Iura. I'm acquisition editor at Elsevier on the biomedical engineer books portfolio. And it's my pleasure to be here again in our second global perspective on medicine and rehabilitation and robotics webinar series. In this second webinar, for the first topic, we have Dr. Maikutlo Kebaetse from the University of Botswana, talking about disability and rehabilitation in Botswana, challenges and opportunities. He's a clinical rehabilitation scientist, and he also practices as a clinical rehabilitation consultant. For the second topic, Dr. Rochelle Mendonca from Columbia University, talking about the role of assistive technology in improving function after disability. She's an assistant professor of rehabilitation and regenerative medicine. But first, let's introduce you all to the creator of this webinar series. I'm pleased to be working with her to develop a new book entitled Rehabilitation Robots for Neurorehabilitation Patients, Professor Michelle Johnson. She directs the Rehabilitation Robotics Lab at the University of Pennsylvania. The lab mission is to use robotics, rehabilitation, and neuroscience techniques to translate research findings into the development of assistive and therapeutic rehabilitation robots capable of functioning in real-world rehabilitation environments. Before I hand over to Dr. Johnson, one quick note. Please submit your questions at the Q&A box, and it will be answered at the end of the talks. Dr. Johnson, the floor is yours.
Thank you, Sonini. Welcome everyone to this new series that we've begun. I just wanted to say a brief word. We're still working out some logistics, but I just wanted to implore that if you have any ideas for speakers, if you would send the email to myself or Yura, that would be wonderful. And then we can try and provide a more diverse perspective in terms of speakers. And we have a poll, so we're gonna try and do a poll every time we begin to kind of get a sense of who's in the audience and their thoughts about certain issues. So if Yura, could you send the poll out? So the poll is asking, do people with disability in your respective country have adequate access to assistive technologies? And so the answer would be yes, no, or not sure. So if you could go ahead and answer that poll, that'd be wonderful. No one's answering? Hey, is the poll out there?
Yeah, people are answering. We have 7 answers so far.
Okay,
Just
wonderful.
leaving for more 20 seconds. I'm closing the pool and sharing results.
Wow, so in the audience, we have about 57% of people in the audience saying you don't believe that there is adequate access. So hence, you know, these conversations. There is a another poll question. Yura, do you want to send that one out? So the other question says, can assistive technologies help to improve function after a disability for people in your country? So we kind of want to get your opinion, your advanced opinion about this, just for our records and for the speakers who are about to talk about these issues.
60% of the people already voted. I'm closing the pool.
Absolutely. So we have believers. So we're talking to the choir in terms of the need for assistive technology. So Dr. Mendonca, be aware of that. So without further ado, we're going to go ahead and start the seminar. Our first speaker, Dr. Maikutlo Kebaetse, will speak for about 20 to 25 minutes, and then he will immediately put the mic over, past the podium over to Dr. Mendonca, and then she will speak for about 20 minutes. Hopefully we don't run out of time, and then we'll leave time for Q&A. Please put your Q&A questions inside the Q&A box. So without further ado, Dr. Kebaetse, you have the floor. Dr. Kebaetse, you're muted. You're still muted.
We can see your screen.
Okay. You can see the screen, correct?
Correct.
All right. Good afternoon, good evening, good morning, depending on where you are from around the world. Thank you for the opportunity to present this topic. What I've done is more of not so much a scholarly presentation, but more of an experience for what is on the ground in Botswana. I've been practicing rehab as a rehab scientist and physiotherapist since 1990. Started training in the US, but then practicing Botswana for 2 years, and then I was away for some 19 years and returned back to Botswana in 2011, and then continued to practice here, but also have been teaching in the medical school. So, I've seen quite a bit. So I'm able to make some comparisons, at least between the US and Botswana. So basically, we're looking at disability in Botswana, challenges and opportunities. So I just define some terms, just operationally for our purpose. I'll just briefly highlight what are considered the major causes of disability in Botswana. And then we look at the selected disability challenges or challenges in disability. And then with those challenges, what kind of opportunities are presented. So most people, when they define disability, they go with WHO, which is what I've also done, so that it's more of an umbrella term. We're looking at impairments, how limited somebody is in terms of activity, and in a restriction in participation. And WHO estimates that there is approximately a bit over a billion people with some form of disability globally. And even though we don't have exact estimates in Botswana, we know those numbers are growing, and we get that based on the growing number of people who claim for loss of earning and disability at the MVA fund. We can also assess that in terms of the aging population. There's an increasing number of the elderly. I was involved recently in a program where developing a policy and program for what they call safer and healthier aging. So those numbers are increasing. And disability may result from a number of factors: physical, as you know, emotional, mental, or developmental conditions. It is a complex phenomenon because you're looking at interaction between somebody's body and also the society or the environment. Sometimes disability is what the environment may actually create. Not necessarily that somebody's not able to do certain things, but all those factors are important to consider. And that is a continuum, from minor difficulties to a major impact on one's life. And that the degree of one's disability and the impact of one's disability is dependent on both internal and external factors. With internal factors, of course, you're looking at something that is within somebody's control. How motivated somebody is. If somebody's going to be compliant with appointments for rehab, for medical visits, and so on and so forth. This can impact on one's disability, as you can expect. But there's some things that are outside our control, being the nature or degree of the injury, the type of disability one has, the kind of family support or structure somebody has, how the public is supportive, how accessible somebody's environment is. And I just highlight that to say proper evaluation and rehabilitation, because this is something that often patients have no control over, especially if you look at the socioeconomic factors. So these are all important factors. So that if there's a compromise in these factors, that may worsen somebody's disability, and what might have been short-term disability may become long-term disability. or something that may not have been so severe may become more severe or more involved in terms of compromise to mobility, to independence. I brought in this term because um, I want you know, in practice and also in looking at disability, I think we should always be interested in what I would call return to work. And operationally, I'm defining this as a process of managing a person who is injured from the time that an injury or an illness occurs to the time that one is able to successfully return to work. Work in this case could mean a job, or more importantly, in general, means return to a level of functionality that is you know, as good as possible, to get somebody to a level that they're as functional as they possibly can. So that is what I call work. Obviously, it could mean someone who's a housewife, or somebody who is a student, somebody who is an employee. So return to work. Now, it's something that requires that there should be very good case management across the various players, multidisciplinary, obviously, so that somebody gets proper treatment and support. And often when this is lacking, and there's always a possibility, or actually the instances where you know that this person, had they gotten good case management, had they gotten proper communication amongst the various providers between the rehab professionals, medical doctors, and so forth, that the disability wouldn't have been that severe. Again, it's collaborative and it's multidisciplinary. And then finally, with return to work, the primary goal again is to bring the injured or somebody who is ill to a level of functionality, and so that they're best prepared to return to functionality, to a level of functionality or work as early as they can, that the target job demands are borne in mind, so that the rehab is focused or targeted, and that they're able to stay at work and be as productive as they can. And in this, in terms of you know, prevention of injury and complications are key components of return to work, and therefore key components of really decreasing the impact of disability. All right. So in Botswana, what are considered the major causes of disability? I've looked at you know, two reports in particular, and for the MVA fund, it's a series of reports that ended in 2018, and they told me that the more recent reports are not available because they usually come out in August, and there have been delays due to COVID. But that technical report, the 2015 one, it was a survey that was conducted as a partnership between several institutions in Botswana and Oslo in Europe. So when you look at causes here, we are considering, or you're looking at with respect to vision, hearing, gait, memory, self-care, and communication. So the self-reports of those who are disabled show that major causes are perceived to be birth and congenital defects, disease or illness, looking at mostly NCDs, but also some infectious diseases also there. When you get annual accidents, there's approximately 450, it ranges sometimes from the low 400s to 480 deaths per year, and about an additional 1.5 thousand that are considered serious injuries. And there's a growing number of claims at the motor vehicle fund, motor vehicle accident fund, where people are claiming for loss of earning support. And those are approaching about in 2018 or 2019, it was about estimated about 2,800 and something. So they're approaching about 3,000 a year. So there's a number of causes, but for our purpose, looked at these as the major ones. Now the higher ones being the first two, birth and congenital defects, and then disease or illness, and accidents being number three. But accidents are important because they are a major contributors to deaths in Botswana. Botswana is around, for every 100,000, the rate is about 20.1 or so deaths. All right. So the challenges with respect to disability in Botswana is that we have a less or underdeveloped health and rehab infrastructure, with rehabilitation lagging behind. By this I mean, of course, the government is doing a great deal of work and doing well, for African standards in terms of clinics, hospitals, and in terms of equipping these health centers. And also there's now 1, 2, 3 private hospitals, and there's a fourth one under construction in the northern part of the country. And there's in terms of rehab facilities, I'm saying they're lagging behind because there has been one rehab facility which is a partnership, or rather an NGO that has been funded from Sweden. It's called Spinalis. I think it has an 8 or 10 bed. It's an 8 or 10 bed facility, strictly for spinal cord injury. One of the hospital that opened about a year ago has set up, understand, a rehab facility also. So we have those two. Other basically just clinics, but you don't have a proper inpatient, multidisciplinary, multi-service rehab facility for the government. There's one that is under construction but hasn't started operating as yet. The problem that we have is that new rehab center is going to face, the public one, is that there is a shortage of professional rehab personnel or rehab professionals. When you look at physiotherapists, OTs, speech prosthetists, orthotists, rehab psychologists, all these, when you add them together, those who have obtained degree and are licensed to practice, both citizen and expatriates, they are approximately about 200 or so. So it's a shortage. It's a major shortage for a country that of a population that is about 2.2 million. Citizens were trained outside until recently, when one local college, was established and providing a number of degree programs, including physiotherapy. But otherwise, you can't get training in Botswana for speech therapy, for prosthetics, orthotics, for rehab psychology, for OT. You have to go outside the country. But a problem with that local college that trains physiotherapists and other professions is that the graduates are considered non-registrable presently. The Botswana Professions Council isn't registering them because there are concerns that these graduates are thought to be inadequately trained or prepared. The government hasn't done anything about that as yet. Hopefully, that will be addressed, because there's a great number of graduates who are training and graduating out of this college, but are not practicing, are not licensed to practice, I should say. Another major concern is that due to low salaries and not so attractive working conditions in the government, many physiotherapists notice when they get to a certain point, 4 years, 5 years, they leave and start private practice or join private practices. So the government is quite having major shortages of staff. If you go to the major hospital in town, in Princess Marine Hospital, people have to wait. You may have to wait for a week or two, and people get less than adequate care in terms of frequency. It may be once a week or once every 2 weeks, because there's just isn't enough physiotherapists, speech therapists to go around for a 300 plus or so bed facility. There's what I call an inadequate legal framework that offers limited protections. The Workers' Compensation Act has some issues there because, and also, yeah, if you look at that one, the major issue that I see there is that Botswana's laws, when somebody gets injured, let's say in a motor vehicle accident, while the motor vehicle accident is doing what it can to help provide the rehabilitation that somebody needs, employers are not required to safely protect the injured person's job. And then when you go to the Workers' Comp Act, and also, yeah, when you get to the Workers' Compensation Act, when you are injured, even at a job, many employers, what they do is that when you're not able to do the job that you're hired to do, and the doctor says, that's an order that says, that you should do something that is less involved in terms of physical demands or light duty. Many employers simply would say, there's no such job here. I see this a lot in truck drivers, who haul fuel, going as far as Mozambique, Namibia, and other places in South Africa. Many of these have back issues, back pain, and sometimes they're found to have disc issues, disc injury, and just getting on and off the truck, in and into the truck, and getting down those steps are steep in terms of the distance between the runs. And when you do that, you're putting a lot of stress on the back, and sitting for long hours also. So you have all these job demands or factors that impact on backache or the condition or the health of the back. So a lot of these drivers often have to be laid off or medically retired, and others. Okay. Also, when you look at workers' comp and then laws governing those in agriculture, farm workers, again, less protection. So that's a major concern. Also, when the establishment and credentialing of programs, training programs also is not tightly regulated. And that's a concern because it impacts on the quality of training. Professional bodies are not adequately involved. And there is it's a disjointed, my opinion is it's a disjointed way of doing things also. So that's another concern. We look at the regulation of professions under the Botswana Health Professions Council. That is quite inadequate. In fact, there are many professions that lack official standards of practice. I don't know of any rehab profession. If there are, it will be maybe one or two that have officially sanctioned standards of practice. These are legal or legal framework issues that need to be attended to. So there's limited protection in general. Okay, obviously, limitations in and of themselves are not a problem, in that they provide us a way that we can then address problems. So I'll start with the one that I ended with in terms of problems that we see or challenges, and that we need a comprehensive review of legal instruments. All legal instruments that are relevant to disability need to be reviewed comprehensively and in conjunction with another, whether it's the Workers' Comp Act, the Motor Vehicle Act, the Botswana Occupational Health and Safety Program, Policy and Program, which a number of us got together to review, but it has never seen the light of the day.
Excuse me, Professor, you have 2 more minutes.
Yes. And then policies related to older adults. We should consider a social network in terms of a social security, so that it's a monitor that all workers through their employers are enrolled in some kind of something that will help them as they age in terms of finances, and alignment with ILO instruments. There should be a vigorous regulation of training and practice that involves empowering professionals to self-regulate. The government should more closely involve professional bodies in setting up new programs, and also when you go to credential. Public-private partnerships are needed to develop infrastructure. We need to build capacity for research and provision of skilled services, so that you have more locals who are properly trained, and programs should be improved that for training, and that we enhance research in this area that pertains to mitigating disability issues. And that is my presentation. Hopefully it wasn't too quick. Thank you.
Thank you, Professor. You can stop sharing your screen. Professor Rochelle, the floor is yours.
Perfect. Thank you. Okay, great. So I'm going to follow up a little with what Mike did, and talk about the
Professor, you are seeing the presenter view.
Oh, I'm sorry. Let me try this. Okay, is this better?
Yes.
Okay, perfect. Sorry. So I'm going to talk a little bit about how assistive technology, or I'm going to refer to it as AT throughout this presentation, can work in improving function after disability for people across a wide range of disabilities. Typically, when we think of assistive technology, we are really thinking about a way of compensating for a disability to allow people to be able to engage in whatever activities they want to engage in, whether it's looking after themselves at home, whether it's going to school, whether it's being able to go back to work. So it really covers the whole range of what we want to be able to do in our lives. I'm going to talk about 2 specific definitions of AT that are quite predominantly used across the world. So in the US, the definition we use most often comes from the Assistive Technology Act of 1998, and is really quite broad when it says that it's any item, piece of equipment, or product system, whether you acquire it commercially, modified, or customized, that is used to increase, maintain, or improve functional capacities of individuals with disabilities. And three main things in this definition are: one, it can be anything. It's not, this definition does not restrict it to only high-tech technologies or low-tech technologies. We're really saying it can be anything. But it has to do two main things. One, it has to improve functional capabilities. And second, it has to be for an individual with a disability. So as long as it meets these three requirements, we can classify things as assistive technology. Another definition that comes from the World Health Organization is actually much broader. And I really like this one because it says that it enables people to live healthy, productive, independent, and dignified lives, and to participate in the education, the labor market, and civic life. Um, so it's really saying that assistive technology has this capacity to engage and allow people to do almost everything that they may want to do. So the World Health Organization definition really encompasses a lot of limitations people with disabilities might have with participation, and it's saying that technology has the ability to bridge that gap. So who can benefit from assistive technologies? And two populations that, most often come up in a lot of our communications or discussions about assistive technologies. One, people with disabilities. And like we heard in the previous presentation, it can be people with physical, sensory, cognitive, emotional, mental health disabilities. Assistive technology can really bridge that gap, and it can be older adults. So we know a lot of the population across the globe is aging, and aging pretty significantly, and also living productively while they are aging. So what can we do for these populations to allow them to live productively? So what number does this, how many people actually fall into these categories? So when we think about people with disabilities, about 15% of the world's population, that's about 1 billion people, have an identified disability. There are lots of people who are not diagnosed or who have hidden disabilities that might not fall in this number. And with older adults, there are about 143 million people worldwide who fall in that group of older adults of 60 or 65 and older, who might have the need for assistive technology. So this is a pretty large number that we're talking about. We're not talking about a small number of people. When we think about people with disabilities, really what we are trying to address through assistive technology is impairments, right? What kind of impairments do people have, and what can we provide in terms of technology to help address some of those impairments, or help them complete their daily life activities even with those impairments. And typically when we think of impairments, we think of sensory, motor, cognitive, or behavioral impairments. And these are easy to kind of categorize in our heads. But when we actually go into more detail and think about it, there's a lot of variability even within these three categories. So sensory can range from low vision to blind, to people who might have some hearing impairment, all the way to allergies. And we need to think about this whole range of people with impairments. And it's the same for motor and cognitive behavioral, where the range is very significant, and we need to figure out what kinds of technologies are going to be best able to meet all of these ranges of disabilities. There's a definition that I really like, which is very simple. It's not federal. It's not mandated anywhere. But this definition was provided by Mary Pat Radabo, who was she was the director of the Disability Support Center at IBM, which did some of the most groundbreaking initial computer kind of technologies. And she said for most people, technology makes things easier, which is true in all of our lives. But for people with disabilities, technology makes things possible. So she's really talking about technology as a lifesaver, as an equalizer for people with disabilities, to allow them and give them an even playing field so they can be at level and have the same opportunities as everybody. There are many, many, many different classifications of assistive technology devices out there, but there's one that I really use that I find very easy to use in practice, as well as to communicate with clients, with patients, or with other healthcare providers, where technology is classified in three ways, where it's low tech, mid tech, or high tech. And this is really a language that patients understand really easily. So low tech it's really inexpensive, it's easy to learn, it's readily available. It can be things you just find in a supermarket or in a commercially available store, and they're easy to maintain or to replace or to make because they're not very expensive. Mid-tech is somewhere in the middle, which they may cost a little more and may require some training. In some cases, they have specialized design, and may need some kind of either electrical power source or battery power source in order to operate. And high tech at the other end is typically much more expensive. People typically require very specific training to learn them, and they may require ongoing support or maintenance, and often it's customized. So just some really quick considerations when we think about AT. Um, as a therapist who works with people and provides assistive technology all the time, the question should always be, what is the assistive technology and what is the goal? But the eventual answer is that assistive technology is only a tool. The goal is not to give a person the technology. The goal is to actually allow them to do what they want to do. If they want to be able to cook by themselves, or if they want to be able to get to work by themselves or operate a computer by themselves, that is our goal. We can give them technology to support that goal, but the goal is never the technology. And technology, like I said, can be everyday simple and inexpensive, but it can range all the way to complex, customized, and costly. Another factor that we always have to consider in assistive technology is cognition. And the one thing I like hitting home for everybody is that cognition should be considered, but it should be never a barrier to why you're not giving somebody a technology. We should not be saying that a person does not have the cognition, at least for day-to-day use technologies, to not give it to them. We can always adapt and customize technologies to make sure that people with different cognitive levels can still use them. And finally, a big thing, and this is an issue across the world, where if you're giving somebody a piece of technology, you have to make sure that they're ready to get it. They should be motivated. They should have the right support system. They should accept the technology. Otherwise, you might give it to them and it just lies in their closet and they never use it. So you want to make sure the time is right and the person is ready. There are, again, a number of different ways of how assistive technology devices have been categorized. So there are different taxonomies. I looked at a number of them out there and came up with this list of about 20 different categorizations of technology. That can range all the way from assistive living to, activities of daily living, to workplace technologies, also to recreation and leisure, or in some cases, technologies are classified for specific types of impairments like deaf and hard of hearing or deaf blind. um, in all of these cases, you can find technologies that are specific to each of these areas of function or each of these impairment types. I'm not going to talk about all of these, but there are a few I want to highlight over the next few slides that actually meet specific needs. And you're going to see that the kinds of technologies I talk about are things that we can even make at home. And this is often what I will do for clients who might not have insurance or might not have a lot of money, is just figure out easier ways or homemade kind of ways of addressing some of these needs. So in terms of if people want to dress themselves independently and may have only one-handed function, or maybe really limited in terms of the amount of strength that they have or the amount of range of motion that they have in the upper extremities, we can do simple things like just changing all of our buttons to Velcro closings, which for a lot of people, this makes the task completely possible now, which they couldn't do earlier. We can even use things like zipper pulls, where people who might not have the fine motor coordination to hold on to a zipper can actually use the pull, which is an enlarged surface area for them to pull up and down to use their zippers. We can also give them specific types of technologies. There are button hooks and there are dressing sticks. I've made button hooks out of just using wire and just sometimes in some cases just towel. Dressing sticks can actually help people pick up their pants from the floor and put it over their legs, or pick up their shirts and put it over their hands. We have lower extremity dressing kind of tools, where there's long handled shoe horns for people who might not be able to pull their shoes over the back of their heel. We have sock aids to help people get their socks on if they can't bend over. And also, this is something I recommend everybody does, is just replace your shoelaces with elastic shoelaces. It makes life so much easier, not just for people with disabilities, but for everybody. There are lots of bathing technologies out there. So some of the most simple ones that we give almost everybody are shower chairs and grab bars. And you can see both of those in this picture here. But this makes the whole task of showering, one, possible, and second, safer. So you want to make sure that the person can get in and out of their bathtub and does not fall over. There's a lot of literature out there that says about 85% of the falls that happen in the home are in the bathroom. And so as much as we can make the bathing task easier, we want to do that and safer. There are also lots of adaptations you can make. You can increase the handles of almost everything people use. So if you look at the second picture here, the middle two are just scrubbers that people who might not be able to reach their back or not be able to reach the bottom of their legs can actually use long-handled scrubbers. The other item in the picture here is actually called soap on a rope. So we put a piece of soap at the end of a longer rope or a longer device, so people can actually soap the back of their backs or the bottom of their feet. This other thing is something I've actually made just out of towels, where you make a little pocket in the towel, you put a piece of soap in there, and for a person who might not be able to grasp that bar of soap, they can actually just put their fist in there and move that piece of towel around, and it helps them again get soap over their body. Handheld showers are great because they allow people to be able to sit and still bathe independently. And again, long-handled scrubber is another example of allowing people to reach when they may not have a range of motion. Grooming, increasing, just like we did in bathing and dressing, increasing the length of every device or every type of equipment that they may use to groom. So brushes, combs, hair washers, just making them longer. It's just surprising when you make things longer, how much more possible it makes this whole activity for people with several types of disabilities. For people who might not be able to press onto a toothpaste, having toothpaste dispensers. And this is a commercially available toothpaste dispensers, but I've also used long binder clips in some cases, where the binder clips can just be put on and the person just presses and it dispenses the toothpaste. Nail filers, this is just a commercially available brush, but actually for people who might not have two hands or not have the ability to use both hands, using this brush actually files your nails, and you can do it one-handed. The picture at the bottom is an example of a woman who wants to dry her hair, does not have use of one hand, but you can mount the hair dryer. I've done the same thing for toothbrushes, where people who might not be able to use their hands to brush their teeth, if you just mount the toothbrush on the sink, they can actually move their head and brush their teeth independently. And finally, using things like enlarged mirrors or giving them larger viewing areas for people who might have any vision issues. We then have a lot of equipment around toileting. So the main thing is, does the person want to be independent toileting? And if they do, we have to make sure that they're safe as they sit on a toilet bowl, or however they decide to complete their toileting activity. So the picture on the left is just a regular walker that's mounted behind the toilet. It's not specifically bought grab bars. It was just a regular walker, and it's really, really safe actually, as long as you tell the person to hold on to both sides. You're not supposed to hold on to one side. And you can sit and get up independently. The other picture is for a bedside commode. So for people who might not have the ability to go all the way to the toilet, you can set up a bedside commode. And these are relatively inexpensive kind of devices. And then again, I can't emphasize enough how much long-handled helps. So the picture on the top is, all of these pictures are of a device called the Wonder handle. But basically, it allows you to either put toilet paper, if you need to shave, putting a razor in. It has an ointment application device for people who might not be able to reach to their private parts as they are completing toileting or any self-care activities. Eating is another thing that a lot of people want to do independently and gives them a lot of independence. So I put in a bunch of pictures here that range from simple homemade kind of devices to commercially available. There are so many ways we can modify eating utensils, from making them large handle, from making them so that they don't require grip, just putting it around somebody's palm, to having rocker knives, which actually are a great tool for people who might not have strength to cut. A rocker knife does not require as much strength to cut as much as a regular knife does. Changing the angle of spoons, forks, and knives, so it accommodates to people's different body types. And then also using towels. Instead of using built-up handles, you can use towels as your build-up. You can have different types of plates where you can prevent people or avoid people dropping food off of their plates. Or you can have, this is a magical thing for most of my clients. It's called Dysim. It's generally blue or green in color, and it prevents any kind of slipping. So if you put any utensil on Dysim, it's not going to slip. And last, you can modify drinking utensils for people who might need them. Sleep is another activity that has not received as much attention, but is receiving it more and more now in terms of the assistive technology world. So we've lately started looking at beds and their ability to enable people to sleep comfortably. So looking at the length of the bed from the floor, the width of the bed, the amount of support in terms of grab bars that it has on either side. We also look at ways for people to get independently in and out of bed, whether they are children or whether they are adults. A lot of people want to be able to do this independently. So lifts, which are always a higher cost alternative, and it's not always possible, but it's out there. And then nowadays, there's so many free apps out there to allow people to sleep and have better sleep hygiene at night, which again actually is considered assistive technology. There are lots of people who need to go back to school, especially kids and kids with disabilities. We want to enable environments that allow them to do that. So assistive technology in schools, some of the major categories they may fall in is, one is just how are you allowing children to sit so that you can encourage them and enable them to study better. So that is one of the things that we highlight in terms of adaptations to sit. We also talk about some of the writing pieces that we can, like how do children write? How do children cut? Because they're cutting in school. How can we adapt technologies to allow them to do this? And I put this material under home and work management. For some people, it may be work, and for some people, it may be leisure. So there might be people who need specific adaptations in the way they sit at their tables or the way the keyboards are to enable them to work. But for some people, this is actually leisure. You might have people with disabilities who want to play games online, who want to communicate with family online. And so thinking about how we allow them to access this technology, both in terms of how they sit at their table, as well as the way they use keyboards or the way they use their screens of the computer. There are lots of very simple and sometimes really easy to make technologies, like line readers for people who can't keep track of lines, paper positioners for people who might need paper positioned at different heights. There are talking calculators out there, which are great. There are also digital recorders, and I found this one online, and it was about $3 or $4, which is very interesting. But it actually records your voice, and then once you enter it into the computer and you have a program, it will transcribe it into written language. So you don't have to sit and type. You can actually do this pretty independently. And another big area that's been something that assistive technology specialists have been looking at for a while is agriculture. I've seen a lot of this in the rural US, but I'm also seeing it more and more internationally now. About how do people who need to do agricultural work or planting and how do we get some of this to actually, how do we allow people with disabilities to engage in this more, whether they need to bend down, whether they need specific grippers, whether they need to get onto tractors or not. So really looking at some of these different types of technologies, again, a lot of which we can make and modify really easily. Reading, writing, computer access. So there are lots of magnifiers, types of keyboards, note takers, mounting devices that actually help people in this respect. Hearing, alerting. So for people who might be hard of hearing, who might not be able to hear, giving them ways to communicate over the telephone. Smartphones have made that really easy now. Giving people the ability to to get alerts on their smoke alarms, on their alarm clocks in different ways other than just being able to hear it. And then there are lots of communication devices out there that can also meet this need. Another thing I want to highlight, which is becoming more and more common, is different types of switches, which was the way we used to go for people to be able to run their devices. But now we have things like the Alexa and Echo and Google Home that are making monitoring and management of the home environment really easy nowadays.
Professor,
Mobile,
1 minute.
okay, mobile technology, apps, right? Apps are almost called this multi-modular kind of technology, that where you can transport, where if you can make things electronic, you can almost convert them to almost any other type of technology out there. Mobility, and I'm not going to go into detail here, but there's a lot of there are different kinds of technologies out there in terms of wheelchairs, in terms of just allowing kids to be able to be mobile, and the sooner you can do that, the better. There's literature out there, and two things I want to highlight really quickly is we can make technology out of 3D printed material nowadays. This is what most of us are doing. Almost a lot of clinics as well as a lot of universities are donating 3D printed material for us to make it for people with disabilities. So it's becoming a lot more easier for us nowadays and cheaper to make some of these technologies. And another project that I've been doing for about 4 years now is making technology out of cardboard, especially for kids who grow really quickly and might need adaptations often. So these are some examples of some of the technologies I have built over the past several years with some of my students for kids with disabilities, to allow them not only to be in school, but also do other activities that they may want to do. And just to highlight what Mike had said previously, in terms of if you're giving somebody a technology, you want to make sure it's right. So you want to make sure there's a professional who can evaluate, get the right one for you, train you in doing it, and then using it, and then making sure that it works even several months after you've given it to them. And then thinking about the barriers to AT, right? Availability is always an issue. Cost is always an issue. And so sometimes you have to be creative in how we give it to them, thinking about the environment where they're going to use it. You may give them the best technology, but the environment may not support it. Attitudes is another issue, how other people see me if I'm using technology. And just some of the other reasons, like thinking everything is high tech. That's not true. There's also a lot of lack of knowledge about what's out there, and lack of perceived skills by professionals. So a lot of professionals don't feel they know enough about technology to give it to people. So I'm going to end there, and thank you for paying attention. And I think we can take questions now.
You have two questions in the Q&A, Yura.
Yes,
So-
we do have. The first one was submitted anonymously. So what recommendations do you have for rehab students who are passionate about working internationally in low resource communities? How can we as students prepare for working internationally in order to most effectively support the communities in what way they need?
That's a great question, actually. And I think this is passionate. So I can answer, and then I think, Mike, maybe you can answer. I think, at least from my perspective, I've worked in a couple of international countries, and um, understanding the culture of that country, I think, is first, and knowing how people view rehab, how people view independence, and how they view different ways of being able to meet the needs of that community. And knowing that if you're going to work internationally, you can't do it alone. You have to find people in that country who can be your partners, and you can actually work with other people to make sure you're meeting the needs. Maybe Mike, you can answer from your perspective in Botswana.
Yes. Thank you for the question. For Botswana, the process is quite straightforward and not difficult at all. Um, first of all, there has to be an OT, and it's easier. And I would advise that students do it in a government facility, because if it's not a government facility, or if it's not a hospital, but mostly a government facility, You want it to be that, because if it's not, then number one, you have a limitation in terms of the variety of cases that you can come across. But in a government facility, you have a lot of cases. The caseload is high also, so you get pretty busy. But then you have to have an OT there. And either the OT themselves, if you contact them, they can then take it from there and contact the Ministry of Health and Wellness. There's a rehab director, uh, the national rehab director at the ministry level, who can then assist, make those arrangements. Or if you have a way to contact the ministry directly, you can do that. But it's easier the if the OT does that. I also can help facilitate that if people send me requests, I can help facilitate that. But it's something that is encouraged, and you don't require a license. Obviously, you'd have to have your own insurance.
Okay, we have one more question here. Dr. Mendonca, the response to the survey question suggests that most attendees believe assistive technologies are not accessible to large swaths of the population, even though their efficacy is universally accepted. The easy explanation might be that the usual economic inequalities globally might make them impractical in some areas of our countries. Do you agree with this view, or in your experience, are there any other factors at play that may not be obviously to the casual observer? I'm particularly interested in any issues arising from cultural consideration, if you are aware of any.
Absolutely. So I think economics is a big issue. And also the perception that all assistive technology is expensive. So I think sometimes because there is that perception, it's not even considered. It's not even taken as an option. Economics is a big issue, but there's also very definitely cultural perspectives. There are lots of countries, and several countries I've worked in, where a person who uses an assistive technology is viewed as being different, is viewed as there's a lot of stigma attached to it. And sometimes it's from the perspective of the user, where they don't want to use it because they don't want to be seen as being different in any way. From simple things like hearing devices, just having a hearing aid. When I used to work in India, and people over there did not want hearing aids, even though they knew it was going to be extremely beneficial and improve their function. It was not something that they readily accepted. So I absolutely agree with your view that it's there are economic issues, but there are also cultural issues, and sometimes it's training. So we don't have enough professionals who are trained around this issue to feel comfortable to be able to prescribe and train and explain to people about assistive technology.
Mike, do
Okay,
you want to add anything?
For Botswana, it's more of a cost issue than anything. I mean, for example, yesterday, no, on Monday, I was looking for a platform crutch for somebody who had a right ankle fracture and metatarsal metacarpal fractures 2 to 5 from a motorcycle accident, and I called everywhere and couldn't find that. But then once somebody found it, the cost was just prohibitive. It's this side is both availability and cost. I think those are major constraints more than culture.
And I wonder, as you were saying that, I thought about the supply, inside the country, as you were saying, if it's not, if everything that is um, the type of tech, the devices that you're talking about has to be brought in to some countries, then the price becomes prohibitive. So part of the challenge and solution is to figure out ways of making the systems in the country so that the cost is reduced
Right.
to have supply chains that are within country, and that everything is not being imported, but there are engineers on the ground. We have people, therapists, or those who are making these technologies and then trying to make them available. I think that's some of the solutions. Even some of the things that Dr. Mendonca showed in terms of the examples. I thought to myself as I was seeing them, are those available in Botswana? You know, and is that even, some of these might not be even practical considerations for Botswana or for another country. I think this is, I mean, I wanted to have these two talks together just to spark some, you know, discussion around it. And I saw that in the chat, there's been a vigorous discussion led by a colleague, Dr. Jaffe, talking about like what is assistive technology, and that it could be a lot simpler. Does it have to be a device? Yes, it doesn't have to be a device. It could be a service. It could be the process of provision. I think we've been focused on the concept of low, high, and medium technology, excuse me, and not just around the service, but I do think that the issue of service and the provision of the process is as important as the device itself, or the system itself. So it's an interesting discussion. I've just been kind of looking at it and paying attention to that. We're actually a little bit over time. I would apologize. We kind of got started a little bit late.
We would like to thank you everyone who joined this webinar. And the next webinar will be in November 18. Please wait for our invitation. Professor Mendonca, would you like to say a few words?
Oh, do you mean Michelle?
Yeah, sorry.
Yeah, no, thank you everyone for joining us, and look forward to continuing this discussion. Again, if you have suggestions for a seminar speaker in the area of, you know, creating this global perspective, I just kind of want to talk about these things. Notice I wrote robotics there just because that's my area, but I'm loose on that, in that it could be low, middle, and high tech systems. I'm particularly interested in kind of bringing high tech to affordable levels in order to serve people with disability in complex ways. So look forward to seeing you guys next month, and please feel free to communicate if you have any more information. Bye-bye.
Thank you all. Bye-bye.
Thank you, everybody.
There's been an active talk in the chat. If you save the chat and there's some exchange for email, maybe those who wanted or were having these dialogues could be noted or facilitated.
And we'll collect all the emails and send to you. Be sure that we'll do that.
Did you save the chat as well?
Yes.
Bye, everyone. Take care. See you next time.
Thank you.